talk about peer respite and supportive programs. And our moderator of this this breakout will be Eduardo Vega, who is the Executive Director of the Mental Health Association of San Francisco and the President of CAMHPRO.
Thank you. For those of you who don't know, CAMHPRO is the California Association of Mental Health Peer-Run Organizations. We're right now the primary organization working to support consumer advocates and the voice and inclusion of consumers in programs, policies, and practices for mental health across the state. We are now an affiliation of 8 full-member organizations with several in the mix as well across the state, representing counties in the Bay Area, in the Central Valley, and Southern California. Many of you know me through my work with the Mental Health Association of San Francisco and previously Los Angeles County. And I'm very excited to be here and talk with you a little bit about peer respite, which is a model I've been very much invested in bringing to California and helping grow, actually even before I was in California. But the essential thing that I'd like people to take away as we go into today's conversation is something that I think people don't hear very much about. We're going to have a few presenters talk about both some findings and some of the outcomes and evaluation around peer respite programs, and also 2 people who are heading up the implementation of peer respite projects in California. But peer respite, I would like to say, it should be something thought of as an approach, I believe, and a program, certainly a programmatic approach, but something that I think has a wider scope of possibility than has generally been conceived. And part of the reason I'm doing that is because in my work across the country, I've seen various things that actually were never officially called peer respite, but that really work to support people in that kind of capacity. Another reason I think that it's very important is that sometimes there are programs or projects that are innovative and that people really want to do, but they see a lot of barriers to implementation, particularly when those implementations are thought about as sort of kind of related to brick and mortar structures, et cetera. In San Francisco right now, we've been working, and I've been dialoguing with Joe here and also county supervisors who are very excited about implementing a peer respite project in San Francisco that will be a little bit of an alternative to more of the housing or to a traditional sort of housing framework. But the point is that the essence of peer respite, is about people providing a warm, comforting environment based in peer support to help people get through moments of personal intensity or psychological distress. As an example, I think that there are many possibilities that have been kind of developed in different parts of the country that, like I said, fit into the peer respite framework, but aren't necessarily called that. And my hope is that across California, we'll start to think about respite as a core resource for helping people that really don't merit and don't need high-cost, high-intensity services, but can really use something to help them get through difficult times, and in particular be guided by people who have been through those types of things on their course of recovery as well. A lot of you know that I'm a survivor of suicide attempts, and one of the things that really I think is an acknowledged sort of issue across the world, but maybe we don't think about so much in the mental health world, is how much of a psychological leap it is to go from being in a really bad place to considering being in a locked hospital setting, or even in a certain sense going through the process of getting to that entry point, as it's called. Most of you working here in community behavioral health know that our movement is founded on the value of creating resources for people where they live, that can help them manage and live with their mental health conditions and recover successfully in their communities. And resources and programs that support human dignity and that promote self-determination. And more as we move, as we have been trying in California, to a prevention-driven system, or even early intervention, we really need to be thinking about how, as communities, we can embrace a continuum of support in which there's less and less happening at the high-intensity, high-cost level, more and more at the low-intensity, community-based, and for our purposes, pure support levels. Almost everybody kind of recognizes that the gaps there are huge, where your options on one end are, you're feeling really tough and I've got an appointment in 3 weeks, to we can put you in right now if you agree to say X, Y, Z that will get you 5150'd. I like to point out these things from time to time because I think, we're all friends here in a certain sense, and we know what really happens. And I know for a fact, I've been a counselor in many, many places, that 5150 is the way to get people in the door when you want to, even if that is completely based in trying to support people that are going through a hard time, they're not going to get anything else. We've got to move away from this involuntary-based services or nothing approach. And obviously through FSPs and all sorts of other programs in California, we've been doing this for years and years. My conviction is that peer respite, the range of peer respite services really provides the needed piece to help augment our systems of care, so that people can get somewhere where they can feel safe, where they can be supported when they really don't need a clinical service, they really don't need a hospitalization, but they could sure use something that's going to make a difference for them, so that the journey from being in a really bad place to either going through a mobile crisis, going to hospitalization, or potentially killing yourself looks very different. So today we're going to hear from our good friends and colleagues here. I'm going to bring up, well, Yana, are you going to come up or are you going to sit there?
I'll come up.
I'm going to bring up Yana Jacobs first, and then Keris Myrick. Both of them are doing programs in California. And then Laysha Ostrow, who will be presenting on some of the research she's been doing for many years, helping evaluate peer respite across the country. So, Yana, you're exceptionally accomplished, and I have this long bio for you. But I think that the most important thing is that, in your work here in California, you go all the way back to Soteria House and others. So you've seen a range of these alternative models come forward, and I hope you'll introduce us to some of that thinking as well, and also how Second Story seems to fit for you. Thank you.
Okay, thank you. Okay, hello everyone. I do, once again, will invite you to move closer because we had anticipated being on the ground level with you in a room so we could at some point have a dialogue. When we were invited to this policy forum, it was after we had presented at the OAC meeting, and so for me it was a little different because I was like, wow, we're going to come talk to people who are working in the criminal justice arena, and I had to wrap my brain around that, and our panel had to discuss how do we fit into this because, as Eduardo was describing, peer respites in general are really an alternative to our traditional system, and they are very much in a belief of voluntary. People bring themselves to the peer respites. There's no coercion. So I was trying to think, how would we work with, for instance, in Santa Cruz, you just heard our MOST team. And it was hard to imagine a probation officer ordering somebody to come to our peer respite. However, there's lots of ways people could work with the probation officer and say they wanted to come and have a proactive interview with our staff. And if it feels right and it's mutual, they would be able to come in. So that's how I worked out being able to stand here in this arena today, to feel like there might be some creative ways that people who are working with probation could think about the peer movement and the peer services that are being offered and starting to be developed in the state. I did do a PowerPoint, but as I'm speaking, I'm also realizing I want to bring it into the context of how most of you are here today, because it might be more relevant. But let me run through some of the slides. This is our peer respite in Santa Cruz. It was funded by a transformation grant by SAMHSA, and about a year through, they cut all the transformation grants by 50%. And the Mental Health Service Act funds came in and helped fund the other 50% using prevention and early intervention as part of the focus for our respite. And if you move that away, I can't see it. So the model was designed to be pre-hospitalization, so that, you know, right now, as Eduardo was also saying, there's not a lot people can have when they are noticing that they're having signs and symptoms, and if they know themselves well, they know that this is the beginning sometimes of things unraveling in their life, and if they don't get some help, they will end up in the hospital. And for most people, when you end up in the hospital, you've often lost your housing, you've often lost your job, you've alienated yourself from your friends. I mean, your life is really unraveled, and it's a crisis. So my thinking when we were working on this was, how can we get people before that happens, and how can we provide a place for people to come, because people know themselves and they know they're not feeling right or they need some extra support. A lot of people are in housing, and we don't want things to get to a point where they're being evicted. So this respite that we have in Santa Cruz was really focusing a lot on people who are in housing and want to have a place to go and not wait until, you know, if they call right now, they might be told, you know, you don't meet criteria for a 5150, so sorry, there's nothing we can do. Now we have a place where they can self-present, talk to the other peer staff who work there, say what's going on, what they're hoping to get out of being there, and come in for a few days. 2 weeks is considered the max, although there's some extensions that are allowed based on, you know, individual circumstances, why someone might want to stay longer. Everyone, 100% of the staff are peers. They all identify as having their own lived experience. The house is, the service is contracted through one of our nonprofits called Encompass. I'm gonna go on. I told you a little bit about the funding and the contract. The peers are providing the support. We just moved from having a program manager, some of you might be interested in this, to flattening the hierarchy, because this is a trauma-informed care environment, and what was happening was the person in the directorship position had a lot of power, and that started creating a lot of power dynamics that were really just, the place was imploding on a, you know, staff to director level. And so we had some technical assistance from SAMHSA, and we've just started last October really trying to create what we call a shared leadership team, flattening the hierarchy, having a lot more transparency so that people all are learning what it means to, how do you run this place together? It's challenging. We just had a retreat at my house a week ago. Again, we brought in an outside consultant because we're working out together as a team, how can we make this work and move forward. So if you're interested in that, contact me in about a year and find out how we're doing, because it's another part of our transformation, is figuring out how to do things without the traditional hierarchy. Moving along. So we have room for 6 guests. We purposely don't say beds, because that was something we learned from peers, that they don't want to be referred to as a bed. And so in the peer movement and in our house, we refer to having space for 6 guests. It's residential. As I said, the length of stay is 2 weeks. People are responsible for administering their own medications. Sometimes that's an issue for our case management staff. They want to refer someone over to the house, but they're concerned they're not going to be able to manage their own meds. Again, that's something that people need to do on their own. Each person in their bedroom has a locked drawer, and if they want help, they can request that somebody maybe remind them when it's time to take their meds, but the staff at the house are not going to pass out meds like happens in some other residential settings. All of our staff have been trained in intentional peer support, which is a model that was created by a woman named Sherry Mead and her partner Chris Hansen out of New Hampshire. And it's pretty much nationally used in a lot of the peer respites and internationally known. It's a very effective model. I find I went through the 5-day intensive training myself. So that's sort of a foundation of the philosophy that we use in the house. The house is very unstructured in a lot of ways. They have groups, but the groups are designed by the people who are living there at the time to see what people want so that people aren't being put and told they have to go to groups that might not be relevant for what their circumstances are. A little background and challenges for any of you who are thinking of starting a peer respite. Probably our biggest challenge that most people are familiar with housing and mental health housing is that NIMBYism is a huge problem. And we had some horrible NIMBYism when we found the perfect house in a beautiful neighborhood. It had huge, large bedrooms. It had ocean views, which we got criticized for offering to our people, like, why would they be entitled to have an ocean view? I mean, it got ugly, and it got so ugly that the staff finally said, we don't want to be in this neighborhood because we feel so stigmatized that we want to look somewhere else. We finally found a house actually pretty close to our Santa Cruz mental health clinic on the north side. And in some ways it's better because it's easier access to public transportation, which is really critical to maintain normal life routines while people are at the respite. Another thing you should know is that while people are at the respite, they do, if they're going to school or if they have a job, they leave during the day and they as much as possible, will keep their normal routines going. They'll go to their medical appointments, whatever they need to do. Life doesn't stop while they're getting support. What's on this slide? This slide talks a little bit about the training. As I said, the major emphasis is with IPS, but people have also been trained in Red Cross first aid and Serve Safe online food safety, because there's a lot of meal preparation. We don't cook the meals for people. People do, there's food there. People can make their own breakfast and lunch, and there's usually a communal dinner that someone might volunteer who's a guest at the house, or people make it together as a activity. Here's some of the components of IPS. If you want to look at this quickly, I'm not sure I'm going to read through it because I want to make sure other people here have a chance to speak. Just real quickly though, the highlights of IPS is its mutuality, that you're having a mutual exchange with somebody, you're sharing your worldviews, and you're moving forward. This gives you a little bit of a picture of what the staffing looks like and how the recruitment was done. There's a lot of part-time staff. It's hard when you go in there to tell who the staff are because there's so many people who have been through the program now that are coming back as volunteers. It's just where they want to be. And they, I'll come in and I'll see someone that was a former guest and they're vacuuming the stairs. They're planting tulips in the backyard. People just love the community, and it's become a just organically grown community. And on the holidays it's huge. They have huge Christmas parties, Thanksgiving dinners, and they invite everybody who's ever been there gets an invitation to return. So while there's a lot of chores to do to keep the house beautiful and clean, it seems like everybody pitches in and just does it. There is 24-hour staff available, and people can be up all night if they need to and talk. If somebody comes in and what they need to do is sleep. In some of our traditional programs, you're told you have to get up and go to group. In the peer model, people really understand that sometimes the most important thing one needs when they're having an extreme crisis in their life is they just need to sleep. And they might need to sleep for a whole day. People might check, say, hey, you still okay in there? How you doing? You want some tea? But we're going to allow people to sleep, and that's part of the support we're providing while they're there. The referrals come from the case management teams, but they can't send somebody and say, we want a bed for Joe Smith. They can bring Joe over and introduce him, and he still needs to do what we call a proactive interview, basically say what's going on and what he might like to do while he's there. So it's very much self-initiated, and that's a really strong, important component of engaging with people, so that they're there because they want to be there. We do have a van. We do go on trips. We visit, wherever someone wants to go. If they want to go to the beach, if they want to go hiking at one of the state parks. People are treated with a lot of dignity and respect. One of the memorable statements I remember when I came and sat and had dinner one night on my way home was a woman looked at me and she said, Yana, and she was probably in her 50s, and she said, this is the first place that I've come in one of the residential programs where I feel like I'm being treated like a grown-up. And I thought that was really poignant because she was clearly a grown-up. Let's see. Shift by shift, co-supervision. The supervision is peer-to-peer, and they will do this co-reflection and give each other feedback on anything they might have observed, and they take turns doing that back and forth. They do have a monthly staff meeting, of course, where they take care of business that needs to be taken care of for the house. There's computers that everybody has access to. They work on housing searches if they need to. There's musical instruments in the living room, and there's jam sessions. There's a garden in the backyard, board games, TV, the whole thing. So it's a regular house, places where, like you would live. That's where they're living. How am I doing on time? 2 minutes? I'm going to... You'll have access to these slides if you want to see any more of them. Here's another picture of the house. Here's quickly some highlights. The most important one, I'm going to skip to the bottom bold. Staying at the Respite has shown reduces the odds of using inpatient or emergency services by 78%. The way this evaluation was done, and Laysha will go maybe more into some of the detail, but we took the people who have been there at the house and using their age, ethnicity, gender, diagnosis, and their previous history in our databases, we compared the people who used it to a similar group who had the same identifiers, and this is where these results are coming from. HSRI is doing the evaluation component for us. And as I said, I'm going to let Laysha go into that piece a little bit more, and if you have questions, hopefully we'll have time afterwards. Thank you.
Thank you very much. I think I forgot to say something at least was very important about Yana, which is that she's the Senior Behavioral Health Manager for Outpatient Services with Santa Cruz County Mental Health Department. Obviously some great findings there. Second Story is the first extended stay respite, or the only one that's continuously ongoing. There was a previous project that was short-term. In Sacramento. Anyway, obviously we're all hopeful that you will consider, I want to make sure I say this before it escapes me, that you'll consider putting into your MHSA plans resources for implementing peer respite in your area if you haven't done it yet. I know the 3-year plans are coming due soon. So I'd like to introduce my good friend and colleague, Keris Myrick. For those of you who don't know her, Keris is a leading national advocate and really great champion of peer services, as well as a personal challenge to many stigmatizing concepts. Keris is working as the executive director, president and CEO of Project Return Peer Support Network in Los Angeles to tell you about her program. Thank
you. So I don't have a PowerPoint, so if you can stop looking at the screen. Yeah, because actually when we started talking about doing the presentation, it turned from presentation to dialogue. So generally dialogue for me means we're going to be sort of not, okay, so you get it, right? We're still going to have dialogue. So I didn't really have any PowerPoint. But when the idea first came to us to do this presentation after hearing it, a few folks heard of us speak at the Oversight and Accountability Commission on the value of peer-run respites, there was some concern about, well, wait, this has to do with, criminal justice, and, we don't force people to do things and so forth. And in our peer respite, which has been open since July of this past year in LA, in Long Beach actually, I had 2 African-American gentlemen, both who had felony convictions. They were brothers. One was 27 and one was, I think, 25. The 27-year-old was on his 3rd felony and is going to trial. So for me, this is a really important issue to talk about related to access and related to access as well as related to health disparities. So to have, again, 2 young African-American men, utilizing our peer services and knowing that one of them was going to be going off to a trial for his 3rd felony conviction, was also living with mental illness, is a striking reality to me about, number one, the value of our services and working alongside of peers to help them through this process, and 2, how can they be used in a prevention and early intervention way to help sort of stop that process of people sort of getting into criminal justice situations and not having any other place to go. And for African American men in particular and other groups of color who do have issues, they don't have issues themselves, but they're systematic issues related to ethnic disparities in healthcare, how do we make peer services available to them and known to them? And sometimes that means we have to go, of course, where peer services do go, which is where the person is. And for me, that means that working alongside of criminal justice and law enforcement, we do have peer services in Twin Towers Jail. That if that's where we have to go to work with people who need introduction to peer services, I'm willing to do that. And I don't think that's any kind of, I don't know. For me, it's just not. It wasn't kind of an issue, so I'm just being honest about that. So, how many people are familiar with the sequential intercept model? Okay. So the sequential intercept model is a framework for understanding how people with mental illness interact with the criminal justice system. And also it presents those interactions as a series of points where interventions can be made to prevent either further interaction with the criminal justice system, or if folks are already in the criminal justice system, to any further kind of involvement in that system. And I think peer respites can be placed along that whole sequential intercept model very well, especially early on or at the end, or probably around the 2nd stage of the model. So I can talk a little bit about what we do. It looks a little bit like Second Story. When we were funded by Innovations Dollars, MHSA Innovations Dollars, for a 3-year program. And prior to the funding coming out, I did visit Second Story, and I also went to other peer respites around the country. I was able to visit a peer respite, actually several peer respites in New York, and get an idea of what happens in those peer respites. And it was really striking to me that, wow, I've been there before, meaning in my own life early on, they weren't called peer respites. There was a time when I was in college, it was 1992, and I was really struggling in college, and I was feeling very suicidal, but at the same time, I told this story, I was suicidal, but I wanted to do my homework. I didn't want to go to the hospital. I wanted to finish my homework. I wanted to stay in the community that I knew, which was being on campus. And I think that was a sense of, a lot of pain and a lot of distress, at the same time wanting to stay grounded and connected. So when I was able to talk to my resident assistant about that, what was going on, and that I was really worried and scared, the first thing he did talk about was, well, maybe we should think about, do you have a doctor? Do you have this? Oh, no, I've got to do my homework. I got this test coming up. He goes, but wait, what? And I said, no, but I just can't go on another minute. So he said, well, we have this thing on campus called, it's called the Residence Place. And basically what it was sitting aside 6 rooms, they're called a 6-pack, in another residence hall on campus. So there were 2 sides of campus, north and south, and there were one of these reserved on each side of campus. And what you do is, he said, you can go for a couple of days, you can take your books, you can leave your books, whatever it is that you want to do, and you can actually go stay there, use one of the rooms. Their paraprofessional staff were both students, and there was a social worker there also, who were there around the clock. So if you think that would be helpful for you, you know, we can go ahead and make a reservation for you. And I said, yeah, I think that would be a good idea. And it was the most amazing thing to be able to literally just cross the street to go to the other side of campus, but to feel like I was going someplace different, to feel like I was going someplace where people were going to be supportive of me and help me through and be there to talk to me if I had issues around the clock. And if I wanted to do my homework, to do my homework. I ended up not doing my homework. But the reality is that that is the essence of being in distress, thinking things are really, you know, you're going through a tough time, but finding a different way of helping a person through that distressful period of time in a respite-like setting. So our peer respite has 9 bedrooms, but we can actually have 8 guests according to the contract. One of our bedrooms is fully ADA accessible, as is the bathroom. Actually, the whole house is. There's a second story, but the second story only has bedrooms. Everything else is accessible on the first floor. When people come to us, they do come on their own, and it's very interesting. I'm also very involved in NAMI, so I have a lot of NAMI folks calling me, and I'd like my son to come to the respite. And I say, well, would your son like to come to the respite? You know, having to make sure that the person really is making that decision and talking with the staff about, is the respite a place where they want to be? And so what they do is we kind of set it up like we thought of it like a spa sort of hotel thing, which of course, if you say that with Mental Health Services Act dollars and public money, it's like, well, why do they need a spa? But the idea, again, is how do you help people be in a home-like environment that's very comfortable, that's safe? Our idea as well is that folks can stay connected to the community. So just like Second Story and Yana was explaining, people may have jobs, they may have other things to do, and they can do those during the day and come and go. We do offer groups in the house, groups or classes. People do call them classes as well. And we use, everybody was trained in intentional peer support, wellness recovery action plan, Hearing Voices Network paradigm, which is working with people who are voice hearers and helping them to understand the process that they're going through and the voices that they're hearing, so that they're not scary, but actually are tolerable and can live with the voices. And then the other thing is we use 8 dimensions of wellness. And the whole program is really based on the 8 dimensions of wellness, which is looking at the whole person, not just their mental illness, but looking at their wellness around physical, emotional, educational, vocational. Sexual was missing. They wanted to do sexual, but they can't have sex. So just so you know, they can't do that in the house. But it is an issue people want to talk about, and nobody wants to talk about it. So we'll talk about it. That's fine. That's part of their whole health. Some information that we've gotten back is, one of the quotes was, "It was a welcoming environment. I felt respected, and I loved interacting with the staff and the support groups. I could have ended up in the hospital, but Hacienda of Hope," which is the name of our respite, "provided the support and services I needed to collect my thoughts and get my life back on track." According to our contract, guests can stay up to 30 days. When we realized 30 days equaled residency, we said 29 days they can stay. When we told them they could stay 29 days, they did. So we stopped saying that. So what we really talk about is when people come in and do a registration form, which is pretty similar to what they do at Second Story with the interview. They're like registering in a hotel where they get their keys, they get everything to the room, they're explained kind of what happens in the house and the expectations. They are a full part of the house. They help with cooking, taking care of the room. Nobody comes in and does that because we, again, want them to remain connected to the things that they would do in everyday life versus becoming dependent upon us and then not having a harder transition when they leave. But when they do the registration process, they also look at housing issues, and this has been sort of one of our biggest struggles in learning in the process, is many people come to us and they have learned to say they are housed or have a home, and they don't. And so to be eligible for our program, they do need to have housing. I don't say stable housing because I don't know what that means. My housing isn't any more stable than anybody's, and I have a lease, you know. But what we did, one of the things that we did with our respite is it's located in the Villages of Cabrillo in Long Beach. And the Villages of Cabrillo is actually a 27-acre campus that has a variety of programs, housing, and services for people who have homelessness issues, whether it be kind of ongoing. So they can either be in transitional housing, they can be in supportive housing, or they can be in housing for people who have families and children, domestic violence, large veterans program, a Native American program for men who also have substance use issues, and then our peer respite. And so the beauty of that has been able to do connections across the Villages of Cabrillo. So if people we find out, do have housing issues when they join us, we're able to connect them to the services through Villages of Cabrillo so that they're able to get connected to housing. 2 minutes? Okay. I was going to say one other thing. Oh, the other thing that we do, so talking about law enforcement. So we have had a couple, well, we've only had one instance where we did have difficulty helping a guest to leave the program, meaning their days had run out and we needed to have them check out of the program and help them get into another housing situation, which we were able to support through community service supports dollars. We can either do the first month's rent, we can give them housing vouchers for a hotel. There were a lot of different things that we could do, and they didn't want to have anything to do with it. So we did have to have the police come and help us, and actually they were quite wonderful. And so what we did is now we have the local police come and have a coffee and donuts, and it's a big joke. It's like, hey, you guys want to come for coffee and donuts? And they're like, are you making fun of us? And no. But what's happened is they've actually become a very vital part of our community. So they actually understand what it is that we do, how it is that we do it, so that if we ever do need their help and support, they come in with the full knowledge that we have a welcoming community, a community of safety. They don't kind of come in barreling, kind of, wanting to sort of use a lot of force and overpower people, but they'll come in and sit down and have coffee and talk with the person, and everybody knows them now in our house who's come to visit our house. So I think that's been a positive plus to create sort of partnerships in ways that are helpful for people versus traumatizing for folks.
Thanks a lot. I'm trying to preserve some time. Alice, we did start a little late. What's our window at this point? 3:45. Okay, so we've got some good time for dialogue. Thank you. Laysha Ostrow is a PhD candidate from Johns Hopkins School of Public Health, and she's been providing leadership in the evaluation of peer respite as well as peer-run programs across the country for a couple of years. So we've been very excited to develop partnerships with her here in California, and also through Mental Health Association, through the Center for Dignity, Recovery, and Empowerment. She serves on our advisory board. Please welcome Laysha Ostrow.
Hi, so I know I'm supposed to get into the boring stuff about research, but I wanted to have a meta-reflective moment, if you'll allow it. As Eduardo, I think, said, I'm not from California yet. So it's been this kind of a rapid conversation. I've been working on documenting and researching peer-run respite since 2009, and the issues that have come up in California just in the last 6 months for me are things that are never really even discussed in other parts of the country, despite respites being, not exclusively in California. So Eduardo held a community forum in San Francisco in November, and the people wanted to have, in part, an explicit conversation about AOT, or assisted outpatient treatment, or Laura's Law here, and what the connection is to peer-run respites, which is something that I had thought about in terms of, I guess, advanced directives and AOT and things like that. And I posted my PowerPoint slides online afterwards for anyone to see, and got some criticisms from people in other parts of the country, activists and program directors, about why I would even mention AOT and peer-run respites in the same sentence, God forbid that gives, any of you guys, I guess, the idea that those things go together. But that's a reality that we have to face. And then we're asked to do this in the context of the criminal justice system. And, I very much had the reaction, well, these things don't have anything to do with each other. And then if we go there and talk about it, then people are going to think like this is an alternative to prison. And that's where people belong or something. But I think they're important conversations to have because, whether or not we have to be ahead of the game in terms of prevention and alternatives and not waiting until something has already been linked together in policy and financing to then say, well, these things don't go together. And then, I hear Yana and Keris talking, I guess first it was the comment about the house where in Santa Cruz where the neighborhood didn't want them there because why do these people deserve to have an ocean view? I'm sure you've all been to Santa Cruz. There are a lot of beautiful ocean views there that many people get to enjoy, but somehow if you are now a mental patient in a peer-run respite, not only do you don't deserve an ocean view, you shouldn't have it. You've committed a crime. So essentially we are treated like criminals just for being labeled with a mental illness. I have never technically been arrested and I'm terrified of the police just because of that label and my experiences with the police as someone labeled with a mental illness who has been in extreme states. So these things happen, whether we decide for them to or not, and I think it is important to discuss that. I guess it's this big green button. Always hit the big green button. So I think we've kind of addressed what they are. A lot of my work more broadly focuses on exclusively peer-run organizations where people with lived experience are in control of the entire program or organization. Kind of gets to some of the issues that Yana discussed about the shared leadership model and not replicating power dynamics that exist in the mental health system and certainly in the criminal justice system, again, in alternative programs that are run by peers. So this is not completely up to date. It's probably maybe more useful to look at the graph in terms of what's happening with the number of peer-run respites. So this includes both ones that are peer-run, which are independent peer-run organizations that have a respite, and those are peer-operated, which, like Second Story, is operated by the county. So the population's really growing and changing in some ways. And it's really exciting to see that more and more states are getting involved in this. There are new respites planned in New Jersey and Wisconsin, 3 in each of those states, and then in California, as we've been discussing. The research is sparse at this point. Most of the programs do some kind of evaluation or data monitoring. Often it's qualitative interviews or quality improvement processes. Were people satisfied with their stay? What did they like about it? Why did they come to the respite? That's all useful information, but would not typically be considered research or even evaluation. I know people get sick of me hearing this. Hopefully you all have never heard me before. I think there really needs to be more research on this topic. There are a lot of methodological challenges because the respites by definition are very small in order to provide that home-like environment. So I don't know how many of you consider yourselves quantitative researchers, but if you have 2 or 3 beds in a respite, it's very hard to get the power to do meaningful evaluation. The evaluation in Santa Cruz, I think, is one of the best that has been done so far, and they're seeing results there that would be consistent with the hypothesis about these programs, or the one that is most strongly advocated, which is that these programs can reduce the use of costly and inappropriate inpatient and emergency room utilization. I think there are other benefits to the community in terms of building capacity in the consumer survivor movement locally, and providing alternatives for other things and other resources that that are not necessarily framed in terms of reduced ER and inpatient use. I think Keris kind of nicely brought in how similar results may be evaluated in terms of criminal justice system involvement and prevention. And just because you're researching something doesn't, it's an important question. If it's an important question to ask, it's an important question to ask, and you're not doing research because it is advocacy. So there's, significant evidence for consumer-operated programs, that are not necessarily crisis-specific, and crisis programs of all different kinds that are not necessarily peer-operated. So that doesn't really make an evidence base, but I think it's a strong place to go from in terms of being invested in these. So there's, Eduardo had mentioned the respite that was in Sacramento, which I have been told was not a real respite, but there was a randomized control trial there, which showed some good results, so that program has not been long-standing. And that's the only RCT to date of these kinds of programs. These is just some examples of qualitative data that other programs have collected. I think probably all of them have some kind of qualitative interview data from guests. But, just in terms of how people are learning to use the respite or, cope with things in their lives going forward and the satisfaction they feel, a number of different things you can look at that hopefully could then be evaluated quantitatively on a larger scale. Respites have defined their own kind of evaluation and data monitoring, which I think is important. If you want to see what outcomes are important, you have to ask the people who are involved in designing the programs and why did they do this. So my approach to research is always to have community involvement in terms of determining outcomes, data collection, and how results are analyzed and disseminated. I'm sorry I'm rushing through this, but I do want to give us a chance to talk, hopefully. Yana had mentioned the evaluation in Santa Cruz. That second table, that big table that came up at the end was the confounders that they put in they use propensity score matching, because one of the challenges historically in all kinds of peer-run programs or community-based programs even is difficulty people accepting randomization as sort of culturally appropriate, I guess, because at some point you've lost your choice. You enroll in the trial and then you cannot choose which service you use, which is important for the methods, but it can be problematic in other ways. In Santa Cruz, this is a SAMHSA evaluation, so if you say RCT, the program would have never gotten funded. I'll probably never get funded by SAMHSA again either now. So they use propensity score matching, which is a well-established method in observational data, and I think could be very promising for all of these programs in doing evaluation and not having the resources to do randomization or not feeling that it would be appropriate for the guests or the staff. So they've shown significant results in the use of ER and inpatient data matching people who use the respite to similar people who did not. I'm not sure how much of this is necessarily important for this. I've put together these tables in terms of what are the program components that you might want to evaluate and what they mean, and then what exactly you might consider in the evaluation and what kind of measures and methods you may use. This is kind of a work in progress, I guess, sort of my notes on things going forward that people might want to consider. And like Yana's slides, my slides will be available. And I guess the last thing I wanted to say was that my organization, Lived Experience Research Network, in partnership with HSRI, who's doing the evaluation in Santa Cruz, and the National Empowerment Center, are putting together a toolkit on how to evaluate peer-run respites based on what we know today. So we're contacting all of the existing respites and asking them what they've done for research evaluation, data monitoring, data reporting, and then going to put that together in a toolkit so that evaluators and policymakers and other program directors, when they want to do evaluation or have to do some kind of evaluation or data monitoring, know what it is that other respites have done within the country. Like I said, the programs are very small, and there's a lot of heterogeneity, but if we could kind of figure out some common data methods, and it's a problem we face in research a lot, then we could hopefully pool the data in some way in the future so that we have the sample sizes, and are able to define fidelity in some way, although I realize people reject that idea who are not researchers, so that we know what exactly it is these programs are, what they're doing, whether they're doing it the same or whether they're doing it different, and then what the outcomes are. And maybe one day it'll be an evidence-based practice, even funded by SAMHSA with a toolkit. So I think that's it.
Excellent. So thank you, and thanks, guys, for summarizing a lot of really important stuff. We don't want to gloss over anything. These are really exciting programs and projects, and want to see about a couple of questions. And Alice, I don't know if there's going to be an opportunity for Mike in the audience, but let me kick it off with just asking a question in particular to the three panelists here. It seems to me that the variables for the different types of programs, you actually laid out a couple of them, Laysha, but they kind of revolve around things like length of stay, maybe staffing ratios, and number of people. But is there anything that you think, like, if somebody's were to consider a peer respite, either, producing one through an RFA, for example, or an RFP, or was going to develop one as a proposal, what would you identify as the sort of the core elements that you think should sort of be identified in terms of program design?
Well, I mean, the stuff about length of stay or staffing ratios and all of that, the size of the house, how many beds there are, is really going to be dependent on the local context. I think something that is the same across all the respites is that commitment to mutuality and shared decision making, meeting people where they're at. I know this is sounding like a lot of jargon. I hope we're in good company here, but not reproducing the same power hierarchies that are in the traditional psychiatric system, which can be traumatizing or re-traumatizing to people, and not facilitative of recovery if people can't make their own decisions. The voluntary stuff is a whole other bag of problems. The MHSA, you can fund involuntary people, but not involuntary services, and I wouldn't want people to be discriminated against because of their legal status, whether it's involvement in the criminal justice system or under a commitment order. But that gets into confusing territory about if someone's whole life is being dictated to them in many ways, what in fact are voluntary services for that person. The training, most of the respites use intentional peer support, although there are other trainings being developed, particularly by Steve Michio in New York. I don't know a lot about his training. So I think as long as it's really a peer support, mutual support model, where people are sharing in the experience, then it might not be so important what the particular model is.
So, oops. One of the things that, is this on? I have no idea. Yeah. Okay, thanks. One of the things that I think is really vital, that's a difference between peer-run and other types of respite or crisis intervention residential programs, is the sense of being and remaining connected to the community. I think if you've heard people talk about being in a residential setting for support, such as hospitals or short-term stay crisis residentials, everything, again, is done for them. And the difficulty in getting connected back to life when they leave, it's sort of like a culture shock. It's like, okay, but wait, who's going to make my bed? Where's my food coming from? Somebody brought it to me yesterday. Nobody's bringing it to me today. So I think that's probably a core element design as far as the program is considered, is ensuring that people can and stay connected to the community so that they don't become over-reliant on the services that we provide. So when they transition, the transition is not quite as jarring. I don't know if this is really program design, but I think thinking about the funding and how the funding and reimbursement is done, we have a situation in our peer respite where it is done on a 15-minute increment basis, which makes it very difficult to cover your fixed costs. So you have to pay the rent, all of the sort of your fixed cost expenses, which means you have to kind of have either a high rate that you're charging for each 15-minute or hour of a service, or you have to provide a lot of those services, which then feels, I'll admit, a bit sort of imposing on the people that you're supporting. Because are you doing it for billing services, or are you doing it because the need is present? So as I looked again across models, and this I think is the importance of looking across at different models, so looking at New York and Second Story and Georgia, and I've actually asked New York would they help me out in looking at some other models they're familiar with. I found that nobody does these 15-minute face-to-face increment billing. And they do sort of an invoice billing or a day rate or a shift rate. So that's part of our learning, which is good for the Innovations Project. We're lucky we're in Innovations where learning is supposed to happen. But I think that's a really critical point, is how do you get the documentation you need and the county would need or the funder would need in order to know the services are being provided, but also how does the person how does the organization get reimbursed in such a way as not to make the billing sort of the purpose rather than the services.
And I'm going to want to hear more from you about the billing, because I think as we spoke at the OAC last time, that was another issue of, in California, there's not yet peers don't have a particular billing code to use for Medi-Cal, and that's one thing we've been looking at that presents some challenges before we bring in billing, and wanting to kind of maintain the integrity of the peer model. We're being very careful at this point not to put that on this program yet. It's pretty expensive to have a program that's not generating any revenue, when most of our programs in mental health at least are generating revenue to help cover some of the cost. So I'd be curious, Keris, what you're learning from your innovations on that. In our program design, one of the areas that we continue to have some trouble with, and I would highlight it, and I think Keris also mentioned it, is when I wrote the grant, we clearly stated that we would not take people who were homeless, because one of the concerns was that you've got a staff who have wonderful open hearts, and you bring somebody in, and as you know, when someone's homeless, it's pretty hard to be mentally healthy and stable, and so your heart's going to open up, and everybody wants to help. But you also, have to keep people moving through so that more and more people can access the respite. And so we said people who don't have a home to return to aren't eligible to come. What I'm seeing now, looking at details when I go check to see who's there, I am noticing people are getting in who are homeless. Either they will say they have a place to return to and then they find out they don't, and that's honest and true, that they thought that their friend was going to take them back to the couch and they can't go back there. But more people are coming in, and they're being, the staff are letting them in, saying, well, they'll go to the shelter afterwards. And then they ask, we're getting a lot of extensions, request for an extension. So we started out with 2 weeks. Keris said they started out with 29 days. We're also starting to say, don't tell people how long they can stay, because everybody will stay the maximum time. We want people to stay for how long they need to stay, and it might just be a day or a night or two, and then they can go home. But our biggest challenge right now is dealing with the folks who have homeless who are homeless, and it's really hard for staff to turn them away, because they can do a great proactive interview. They have a lot of things they want to work on. There's a lot of resources at the house in terms of ideas that peers give them on where to find other places to live that might be affordable, and yet once they're there, it's really hard to put them back on the street. So we're just really challenged by that.
I'm aware that that's an issue also for the more traditional sort of crisis residential programs, and in particular the step down and other types of programs throughout the state, in which are taking people out of hospitalization, is then they've got to be working from day one. I used to work in one on a discharge plan that involves housing. So really, I'm glad you brought that up. Thank you.
Speaking of
Could you please introduce yourself? Sorry.
Oh, hi. I'm Leoma Lee. I'm on the Sacramento Mental Health Board here in Sacramento. And I'm wondering, what kind of assistance do those people who are homeless get when they can't get into your program, which would probably serve them better than being incarcerated or going 5150 and getting put into SMIT or wherever for 90 or 30 days?
So what we've done, again, because, and I was just telling Yana something interesting that may happen in the future, but so what we're doing currently is we have another program within the peer respite called a peer-run integrated service management model, which has peers working alongside of, it can be people in the house or even people in the broader community, to help them on those 8 dimensions, and one of those 8 dimensions includes housing. So we can use the these other peer supporters to help with connections to housing through some of the services that are in the Long Beach area. Now, generally that will take longer than their 4-day plan. So usually when they come in, instead of saying they could say 29 days, saying they could say 2 weeks, or even saying an amount, we say, what would you like to achieve while you're here? Let's write this down in sort of these 4 compartments, and we'll look at it every day, knowing in our minds it's about 4 days. So, and usually about the 3rd day, we find out, oh, there's housing issues. So that can take up to the 29 days. And we are very, very fortunate that we have a lot of these connections, either because of the Villages of Cabrillo or because there's good resources in Long Beach. I'm really not quite sure that we have not yet had to turn, we've only had to turn, well, the one person out, not turn them out, but we had to get them connected to a temporary housing situation that was just for 3 nights. And we work with the mom. We also have family support specialists in our peer support program who help to work with the family who did not want to take the son back, but in working with them, we were able to have them agree to take the son back and get them supportive services, as well as continue to work with the son even after they left the respite. What we've been talking to Villages of Cabrillo about maybe in the future, should this program continue, is actually putting a peer-run transitional house on the property of Villages of Cabrillo. So then we have the peer respite as well as the peer transitional housing that gives us much longer time to work with folks to get into other types of housing.
Well, that sounds really great, but I'm not that familiar with how they work it here in Sacramento. So you guys have brought up a lot of questions for my little notepad over here, trying to figure out who's doing what to who. So thank you guys for coming down and talking to us about it.
And I'm understanding that Sacramento County is going to be, and a couple of the neighboring counties are starting peer respite projects, or I might be, I don't know, is there anybody who can correct me or confirm that? It's true. Okay. Mike says it's true. Thank you.
You know, the only thing I'd add to your homeless question in terms of what we do is, as I said, a lot of people have gotten into the house who are homeless, and the staff link them with all the waiting lists in town for housing. So in terms of just mostly doing community linkage, because they're very familiar with what the housing options are in the community, so they quickly start getting people to fill out applications. We do have a transitional house in Santa Cruz, and so they get on that wait list. The problem is the wait lists are longer than 30 days. So there's also a shelter. Our shelter has mental health beds. If the person's eligible, they'll try and get into a mental health bed, and then they can come over to the respite during the day and use it as a community support place if the staff and the other guests feel comfortable with that. So we do everything we can to link people to what housing possibilities there are and try and educate people about that.
Thank you.
I have a question. I'm Lillian Scheckner, Alameda County. My question is, I have 2. One is, did you say whether people can return? Okay, so.
Yeah. We actually have statistics on that. A lot of people return. They come back each time and they go through another interview on what they want to work on and what they want to use the house for. But that's probably part of why they're not returning to the going to the hospital, and why our hospital we're showing a pretty high percentage in reduction, because these are folks that might have in the past used the hospital, and instead they're allowed to come back as much as they want, as long as there's space available.
Our program is the same.
I would just say from a research perspective that, I mean, this is something I've been worried about for a while, is that, this issue of the respites becoming a normal good where people, they like it, so they want to come back. At the same time, I think we need to, and I'm not saying that's necessarily true, these are probably people in need who would have gone to the hospital otherwise. At the same time, I think when doing evaluation, we need to be measuring the dose response effect of, is it 1 stay that makes a difference, or is it 3 stays? And, when you're looking at cost, maybe those, even if they stay 3 times when they would have gone to the hospital 1 time, it's still cheaper and more cost effective. So that's something to consider for research.
Thank you. I had a second question.
Go ahead.
This question may be a bit bold and maybe magical thinking, but do you all believe that 1-day respite care could take the place of crisis residential or even hospitals?
Let me speak a little bit to that.
I certainly do.
I'd like to hear a little bit about that, if that's possible.
I worked in crisis residential for an extended period of time, actually, years ago, and I think that the right model might not feel so different if it's done in a really, in a really positive way. It probably, I think that within the crisis residential spectrum, there is still, there is a lot of variation, and there are even, crisis residential programs that are actually housed in on the facility on PUF at PUF facilities and stuff like that too. So, so I would suggest that, at least from my point of view, and I would maybe try to represent CAMHPRO membership, that we feel that peer specialist services are unique, create a unique value that that people would want to have, and the question of whether or not ultimately that would be more value for a system than a more traditional crisis crisis residential, I think is still one that would be very interesting to explore.
I guess it's a complex question. I've worked in the system for over 30 years, and I started by working in a non-traditional environment, Soteria House, if you've heard of it. And what I think the challenge is, because I look at the staff and they would like to take people that are maybe more acute, and I think the complicating part is, like, the Soteria model took people who were having a first break. Having a first break is very different than working with people who have had repetitive episodes and have been very much accustomed to being treated by medications and the traditional system, because you're looking at that's a really different reframe, and it's re-educating, and it's teaching people how to take and manage their lives very differently. And if you have a house of 6 people who are all in an acute state, that can be a really challenging dynamic to have in a house. I think, but as I know, everyone's not like in an acute psychotic state at the same exact moment all day long, every day. It comes and goes, and everybody's quite different. But I think it's a huge training issue, and it's a different target population if you're going to have the peer respite that we're running now, which was really more on the prevention side, then if it's going to be an alternative and be a place where people could come in crisis, I'd really want the staff to have a different emphasis on their training. That would be really critical for, it would be different. With the new PUF that just opened in Santa Cruz, there's more linkage because we have peers working there. And I'm noticing that there's more of a chance now that people are being diverted from the hospital while they're in the crisis stage setting, being evaluated, because the staff there are familiar with Second Story, and they know what's a good fit. And so oftentimes they'll refer someone to Second Story for support, whether, if they really met 5150 criteria, they would be hospitalized, though. But this might be an alternative to going to crisis house, a residential, if they think it's going to be a good match for that individual. We've really placed in Santa Cruz a lot of emphasis on our transition age youth going to Second Story, because it's a place where we're going to not create the traditional cycle, and it's not going to get embedded. And I believe people are going to have a much better chance of getting back on track and getting on with their life and not becoming chronic patients if we can do it after their first break. So people who get hospitalized for the first time after their first break, we're trying to divert them, if we can, over to Second Story, and that's when I made the first change in our length of stay to 30 days, and it was really to focus on the transition age youth, because I thought they needed longer to transition out of the hospital and start to kind of put together and figure out what just happened in their life, why did it happen, and just have some time to really get a lot of support and understanding around that. That's been pretty effective.
I mean, I think the only thing that I'll add to all of that is I agree, and I also think is again, sort of, I've looked around the country at different types of either peer respites or peer-provided programs. I'm also struck by, again, sort of the lack of ethnic diversity of people utilizing those programs. And as we do more exploration of that, sometimes it is the way that we talk about peer services and empowerment that does not resonate with the culture. So I've been told, well, that's an imposition on my culture. We work as a family unit, or we work together, and yes, I have a voice, but this voice is also important. And so I'm always mindful of the either or, and rather than something that looks more like a both and. And if hospital settings and crisis residentials and PUF settings are not compassionate, effective, trauma-informed places for folks to be, then that means that the hospitals need to do some work to be, again, sort of providing services that really help people rather than maybe traumatize people. And then peer services are available also alongside and if needed for many reasons, including cultural relevancy.
There's the the big thing, I think, that the reason I'm always so excited about these programs too, maybe you guys can speak to this, is, we're all familiar with the helper principle, right? So, for so many years, we people who are having experiences and consumers were, in a certain sense, systematically disenfranchised of that, right? So obviously through peer support, the idea that, as an example, I might be at Keris's program one day, but I might also someday be able to work there or even volunteer and support others who have been through those similar hard times. That's the thing where I think that we're really hopeful that, there can be kind of a snowball effect that helps continue to grow people's empowerment and enhance their hope and their sense of opportunity for themselves as individuals who can and should have every opportunity to contribute to others' lives in the same way that our sort of more typical provider systems do. We have time for a couple more questions. Michael, I see you back there.
Yes, we do. We got about 8 minutes.
Michael Hagerty, Nevada County Health Director. We're planning on opening a respite center this summer, and we'll be actually copying a lot of what we've seen from the second story in Santa Cruz. One of the things that's come up in our implementation committee is there's a significant number of people that want to have a clinical piece, and so instead of being 100% peer run, it would be 95%. So we're wrestling then with what would that look like? Would it be a therapist? Would it be a behavioral health worker, a case manager? And so I'm just wondering, if we end up trying to add a professional piece, what do you guys think of that? And do you think it would be totally no, don't do it at all? Or are there models that try to blend peers with professionals?
I'm going to let these guys take it, but I have a gut shot on that because it just came up in a conversation I was having with Kaiser Permanente the other day, which is professionals like LPNs to focus on primary care issues and general health conditions seem like a great fit to me, or even just sort of general nurse practitioners or something like that.
Well, Keris and I just compared notes, so we're going to give you two answers because there's two perspectives at this table. I would say absolutely not. I like what you just said, though, with having a health professional coming in and talking to people about health issues, but I think it would really totally change the dynamic, and you'd bring back in that power dynamic that the peers are really trying to move away from. I think as soon as you bring in a clinician with a license, they have the power. And how we can work together is we're still trying to figure that out, because right now, in some ways, we've intimidated a lot of the clinicians, and our, the case managers are sometimes afraid to even come over because they don't feel so welcome, because the message has been the peers need to bring themselves there. And I've said to the case managers, no, it's not that you're not welcome, it's that you can't place somebody there. You don't have the power to place them. It needs to be their choice, but it doesn't mean you can't come visit your folks. If your folks have a relationship with you and they really want you to come visit them, of course you should come. So I think there's ways to include professionals without putting them on the staff, but having them collaborate and work with the people who are at the house. I mean, sometimes I've thought it would be nice to have a psychiatrist who's more involved with the house, because sometimes people are really having a crisis because their medications are really kind of out of whack, and it would be really helpful to have a doctor that people trusted that would come over and talk with them at the house. So I think there's ways that we could think creatively about how to blend and collaborate, but I think if they get on the staff, what I saw when I visited a New York respite a year ago was the person who was the licensed staff was the supervisor. They were in charge. And then you've got peers who aren't empowered to be running the program anymore, and it really, really changes the dynamics.
So if Kay Redfield Jameson wanted to come and work in my respite, I'd love it. So again, you get somebody with lived experience who's also a clinician, but that's different. But I'm just saying, you're thinking of creative ways, right? So I just gave one. But anyway, so what we've done is, so I'm going to agree, and you know me, I'm going to agree and. Okay, so I agree and. One of the things that we were sort of struggling with is the peers knowing that what they're doing has value. Even though they were getting feedback from the people that were providing them service, they were like, yeah, but they're supposed to tell us that. It's almost like your mom telling you, yeah, I love you and you're great. Well, you're supposed to love me and tell me I'm great. What is that? So I thought it would be kind of interesting to see how this would work, and I brought in a psychiatrist who works in the private setting, and he relies on peer services, meaning in his practice, he uses a peer coach, and he refers many of the people that he provides services to the peer coach, and he cannot speak enough about the difference that this young man makes in people's life. I thought, well, maybe if he gave voice to the power of peers and what peers do and how they help, they might hear the value of what it is that they're doing. Even if it's a kind of a power differential thing, it is sort of this thing, I thought. And they said, yeah, we want to hear from this guy. So we brought him in. And it was probably the most lively discussion I've heard the group have with this doctor about what he does, how he does it, how he uses peers, the value that he finds in it. What does that peer actually do? What did he think it was important? How did they work together? Blah, blah. So I think there are probably ways, again, to find ways to collaborate without necessarily having the licensed provider, whether it be psychiatrist, psychologist, whatever, within the actual program itself. And for our folks, if they're connected to services, their providers do come and visit them in the house if that's what the peer has said they wanted. Yeah, it's easier for me if my psychologist comes and we have a session in the house. Is that okay? Yeah, sure, if that's what you want to do. And also we help people get connected to services as far as if they need primary care or any other type of mental health care. And social workers and case managers are in our house visiting as well and hanging out. We're having a pie party tomorrow because tomorrow is the celebration of pie, P-I. You know what PI is, right? But we're going to eat PIE. So anyway, but the whole community, again, is sort of invited, and we see this sort of as a community resource as well as a peer resource.
So you don't have licensed staff work?
We don't have licensed staff work. They're not part of the staff, but they're clearly welcome in and do come in and feel a part of the community.
Yeah, I mean, you could have people working in a consulting role, you know, if someone, a psychiatrist or nurse, I like that nurse idea, we should talk about that more, are needed in a certain situation where, in fact, the staff who are working there have a say over who can come in the house and when they're actually needed. The other thing I would say is that these programs don't have to be every program. They're a particular kind of program, and so if it's not peer run, it's not peer run, and that doesn't make it bad. It's just another thing, and I mean, my only preference would be to not call it peer run when it's not, but you can go ahead and do that.
Thank you.
Hi, I'm Noel from Trinity County. And Trinity is a very rural, isolated area, and from our perspective, this peer-run model really is an ideal way to provide new resources. In terms of workforce, it's very difficult to find licensed staff, and so if we were going to try to create a licensed crisis residential, it would be very tough and extremely expensive, whereas this model, it seems like offers an alternative because we have peers in recovery who would really like to do this kind of thing. My question, though, has to do with how we can influence state officials. And specifically, this last fall, our state legislature through SB 82 offered grant opportunities to build crisis residential, and I had a conversation with the California Health Facility Financing Authority, who would be awarding these grants. Would they be willing to fund a peer respite program if they got such an application? And they basically hemmed and hawed, and they said, well, let's get back to you. And they got back to us, and they said, well, we're sorry, the law won't allow it. And so I felt like they're really shutting down a real opportunity because this could be an answer to many counties' just need for this type of service. So I'm just wondering what you think about how we can influence.
Well, can I just say that there's nothing that makes me happier than somebody saying something that I've been saying for a while. And I'm really glad that you pointed that out, and actually that there were several other inquiries. Some of you know I worked on the SB 82 legislation a little bit, and it was really tough for me because what ended up seeming politically exigent at the time was to use the language around crisis residential and mobile crisis that was already in statute, and that statutory language is in fact what drove the funding under the current SB 80, the CHAFA release. However, I do think this is the time, and there's several. We should all be thinking about how we can help advance this through our leadership. Robert's not in the room anymore, but I think he said he was going to make it happen. No, I'm just. But I like to. Anyway, I definitely love it, as a matter of fact, if the mental health directors would come behind and support some initiatives around creating space for peer respite to be funded, you know, both through maybe there's an upcoming round, there's another round of SB 82 funding coming out shortly, and create more sort of more general support for peer support in different conditions. And I'm glad to talk with you a little further about your situation in particular as well. One other thing I'd like to ask of the people in the room before the session is over, and especially Sandra, who's here, and any of you other mental health directors, I see you hiding, is to consider if you can help us, CAMHPRO, perhaps develop an idea that came up at the OAC, which is to create a learning collaborative for California, specifically around peer respite. I think there's several really good reasons, obviously lots of questions, but also a lot of value we see coming forward for the community, and that I continue to learn from my colleagues who are doing the programs about what might make sense or what we should be thinking about in San Francisco. But being able to share that learning, and as multiple counties start to work on it, I think would be a really core opportunity. So she's nodding. She said, yes, she's going to do that. I'd just like to give a minute to each of our panelists to offer any closing thoughts, too.
I did not prepare any.
Just that I want to really encourage you, if you're thinking about opening a peer respite, that it actually is a wonderful addition, I feel, and people who are getting to experience it are really happy, and it really seems to be working in terms of just changing the climate, in terms of, we talk about recovery for years, and this feels like a program that's actually living and breathing recovery types of attitudes, philosophies. It's happening there. And so if you're having trouble with kind of connecting the dots, and you have all these programs that are recovery oriented, but you don't feel you're getting the results, I just feel like having a peer respite or any kinds of programs where you are staffing with peers makes a huge difference. And so I just want to encourage you to go for it if you're thinking about it.
So I'll do a ditto, and why not have one last and? But so I totally agree, but I do want to say that starting up a peer respite is difficult. So I just do want to give voice to the fact that we did have, and we're still sort of struggling with capacity issues, ensuring that people know who we are and are referring to us, and people are coming to us. It's a slower startup than we had hoped. And I think that's a reality, and there's some learning curve issues, and you have to be able to sort of tolerate some things that are unknown, and also, like I say, be able to put your sneakers on and dance and go where the dance is going. But in fact, it's very, very rewarding, and I do hope people will take on that challenge because it's worth it, especially for the people who so desperately need our services, because all of us can't do it alone. We have to kind of work on this all together and provide as many and a variety and types of services as possible, with peer respite included. Thank you.
Thank you so much for being such an attentive group and for the opportunity to present. Alice?
And I want to thank the panel, and I think we're on a break until about 4 p.m. and come back.